Good afternoon and welcome to ICE webinars. Today we are joined by Tricia Trammell, Imaging Operations Manager at UT Southwestern Medical Centre. Tricia has more than 26 years in the healthcare profession and over 16 years of leadership experience. ICE webinars would like to thank our sponsor, RSTI. Since 1985, RSTI has been training service engineers in the repair, maintenance and troubleshooting of diagnostic imaging equipment, which allows healthcare providers a cost-effective solution to servicing their medical imaging systems compared to OEM contracts. Training certificates received from attending RSTI classes are globally recognised, so for more information, please visit rsti-training.com. Now, just a quick reminder to save the date for our 2025 ICE Expo, which will take place at the Rosen Plaza Hotel in Orlando, Florida, from February the 22nd to the 24th. The Imaging Conference and Expo is the only conference dedicated to imaging directors, radiology administrators, and imaging engineers. Now, ICE offers valuable CE credits from the ASRT and ACI and is a unique community of key decision makers and influential imaging professionals. So for more details, please visit attendice.com. Now, today's webinar is eligible for one ARC Category A CE credit by the HRA, and you can obtain your CE certificate by completing the post-webinar survey, which will be emailed 1 hour after the completion of today's webinar. You must complete the survey to receive your one CE credit, and you'll be able to download the certificate directly from your computer once the survey is submitted. If you have any questions, you can reach us at webinar@mdpublishing.com. We'll be wrapping up today's presentation with a live Q&A, so please submit your questions anytime using the questions feature on the webinar dashboard. Let's kick off today's webinar by giving away one of our ICE gym bags to the attendee that can tell me the answer to the following trivia question. November is Pancreatic Cancer Awareness Month. What colour ribbon has become the universal symbol of pancreatic cancer? Answer now using the questions feature on your dashboard, and I'll reveal the answer at the end of the webinar. Now, as I mentioned earlier, Tricia is our presenter today, and she'll be discussing understanding breast risk assessments. So Tricia, you may begin whenever you're ready.
Thank you. And thank you all for joining me today. I really appreciate this opportunity to speak to you all today about understanding breast risk assessment. As she mentioned, I've been in the imaging field for over 26 years and been in leadership for more than half that time. I am a registered technologist by background, and I'm registered in radiography, mammography, quality management, and breast sonography. I'm also a certified radiology administrator and a fellow with AHRA. And I'm also a certified breast navigator and have been since 2012. I've helped develop and implement an imaging navigation program for 2 health systems in the Dallas-Fort Worth Metroplex. And I currently manage 2 ambulatory imaging clinics for an academic health system in the Dallas-Fort Worth Metroplex. And that academic organization that I work for is a breast imaging center of excellence. We have commission on cancer accreditation. We are in national accreditation program for breast centers, and we are a National Institute of Health Comprehensive Cancer Center. And if you saw my picture there, I've got a haircut since then, so it looks a little different. So I just want to talk a little bit about some breast cancer risk factors. We're going to talk about breast cancer risk factors. We're going to talk about breast cancer risk assessment, and we're going to talk about how to manage high-risk patients. There's a lot of misunderstanding about how to manage high-risk patients, so we're going to talk about that a bit today. But we're going to start with the basics, and this is going to be probably a review for a lot of you, because most presentations about anything having to do with breast cancer or breast imaging, of course, starts with some breast cancer statistics. So that may be a review, but we know that approximately 13%, and that's about 1 in 8, of United States women are going to develop invasive breast cancer in the course of their life. In 2023, an estimated over almost 300,000 new cases of invasive breast cancer were diagnosed. And that's along with over 55,000 cases of DCIS. In 2023, an estimated 2,800 new cases of invasive breast cancer were diagnosed in men. A man's lifetime risk of breast cancer is about 1 in 833. So it's obviously, we know it happens. It's obviously not as common, but we know it happens. There are currently more than 4 million women with a history of breast cancer in the United States. This includes women currently being treated and women who have finished treatment. In the United States, less than 1% of all breast cancers occur in men. But it's being talked about, and it's certainly being talked about more than it ever has. And in fact, breast cancer itself is being talked about more than it ever has. Just the color pink is being talked about more than it ever has. It's just a different day that we're living in. Women didn't talk about breast cancer 30 years ago, 40 years ago, and now it's a whole movement. But the bottom line is that women in the general population have a 10% chance of developing breast cancer by the age of 80 years old. And we're going to talk about why, and we're going to get real granular with all the reasons why that's happening. Let's talk about incident rates and death rates and what's going on with that. Breast cancer death rates have been decreasing steadily since 1989 for an overall decline of 42% through 2021. We know this, we've been watching it. The decrease in death rates is believed to be the result of finding breast cancer earlier through screening, increased awareness, as well as better treatments. But what's happening? The death rate is going down, but the incident rate is going up. We're finding more cancers. People are dying less, but we are finding more. It's happening at the same time. We're screening more patients. Patients are becoming more aware of screening protocols. So we're finding more cancers. Treatments are getting better at the same time, so people are not dying the way they were before. We're finding cancers earlier. So incident rates are going up, death rates are going down. It's a phenomenon, and there's lots of investigations as to why this is happening. But let's talk about some very most recent time periods, some cancer occurrence in the most recent time period. So female breast cancer incident and mortality rates for 5 broad racial and ethnic groups are shown right here. So breast cancer incident rates are the highest in white women, followed closely by Black women, and are the lowest in Hispanic and Asian Pacific Islander women. Importantly, these are aggregated rates for the broad racial and ethnic groups, mask possible heterogeneity with subpopulations. For instance, breast cancer incident rates of Native Hawaiian women are like those of white women. Of the broadly defined racial and ethnic groups, here's what's important. Black women have the highest breast cancer death rate. It's 40% higher than the rate in white women, and more than double that of Asian Pacific Islander women. This is something we have got to pay attention to. We're finding more cancers in white women just slightly less in Black women, but more Black women are dying. What is going on? So there's been a lot of studies about why that's happening. Some of the things are Black women are being diagnosed at later stages, and some of the cancers that they are having are more aggressive cancers, triple negative, HER2 positive, things of that nature. There's a lot of studies going on, and we have to be educated about what is happening. I don't know if you guys are working out there in the field, if you're seeing what's happening. I am seeing it. Breast cancer on the rise in young women. I teach some navigation classes, and I show a lot of studies, pathology reports, and actual images. I am seeing a lot of premenopausal breast cancer. A research team analyzed data from over 217,000 US women diagnosed with any type of breast cancer from the year 2000 to 2019. In 2000, the incident rates of breast cancer among women ages 20 to 49 was about 64 cases per 100,000 women. Over the next 16 years, that rate slowly went up, increasing about 0.24% per year. But by 2016, the rate had reached about 66 cases per 100,000. But after 2016, for reasons researchers do not know, the trend made a steep uphill turn, suddenly increasing at 3.76% per year. By 2019, only 3 years later, the rate had reached 74 cases per 100,000. And that's information we have up to 2019. I'd like to know where we're at today in 2024. And I believe that when we do have that data, it's going to be even more shocking, because as a person that is working not full-time, but even somewhat in navigation, I am seeing a lot of premenopausal women, even in their 20s and 30s, being diagnosed with cancers and aggressive ones, triple negatives, triple positives, and cancers with very high Ki-67s. It's very scary, and it really makes you wonder, what is happening? What is going on? So let's just talk about what is risk. What is the definition of risk? So absolute risk is the likelihood of being diagnosed with cancer over a certain period. For example, the absolute risk of breast cancer increases with age. 13 out of 10,000 women ages 40 to 44 versus 23 out of 10,000 women ages 50 to 54 will be diagnosed with breast cancer in the next year. That's absolute. Lifetime risk is the absolute risk of being diagnosed with cancer anytime between birth and death. Lifetime risk of breast cancer reflects the average probability of a female being diagnosed with breast cancer in the US. A woman living in the US has a 13% chance of being diagnosed with invasive breast cancer in her lifetime. Another way to say that is that 1 out of every 8 women will be diagnosed with breast cancer in her lifetime. However, it's important to keep in mind that risk varies substantially based on individual factors. And when we do a risk assessment, we're often looking at a 5-year and a lifetime risk when we're looking at various assessment models. And when we consider what is high risk, we're looking at a person that's high risk as being anything that's over 20%. But we'll talk about that a little more in a minute. So relative risk compares the absolute risk of disease among people with a particular exposure to the risk among people without that exposure. So if the relative risk is above 1.0, then the risk is higher among those with the exposure than without it. Whereas the relative risk is below 1.0, the exposure reduces the risk of disease. For example, one study found women ages 50 to 59 who were current users of combined estrogen and progesterone menopausal hormones had a relative risk of developing breast cancer of 1.2, meaning they had a 20% higher risk compared to women who have not used hormone therapy. While relative risks are useful for comparisons, they do not provide information about the absolute risk of an exposed group. In fact, when the absolute risk is low, even a large relative risk has little influence. In this example, 27 breast cancers per year would be expected to be diagnosed among 10,000 women ages 50 to 59 who've never used menopausal hormones, compared to 33 breast cancers among 10,000 women of the same age who have had estrogen and progesterone. Thus, 20% increased relative risk is the equivalent of 6 additional breast cancers per 10,000 women per year. These risk terms can be a little bit confusing. So let's just talk about risk factors. And we're going to talk about some of the common ones. And I'm not going to go into all the details, but we're gonna talk about the highlights of each thing. And then I'm going to go into some that you might not know. And I hope that I tell you something today that maybe you didn't know. Oh, but we'll just touch on it. Of course, we know gender, age, family history, genetics, personal history, race, chest radiation, weight, and that's something we're just gonna spend a minute on. Pregnancy history, breastfeeding history, menstrual history, and I want to spend a minute on that as well. Hormonal exposure, and that is a big key. Alcohol, breast density, exercise, and of course, poverty. Okay, so family history. We know that family history is going to impact our breast cancer risk assessment. We know that it can change our risk assessment, but what is the bottom line? So our risk of breast cancer is about 1.5 times higher for women with one affected first-degree female relative, and 2 to 4 times higher for women with more than one first-degree relative. When is this important? This is important when we're looking at all the different risk assessment models, and some of the risk assessment models look at first-degree relatives. Some of the risk assessment models look at first-degree relatives and second-degree relatives. We will look at that a little more in a minute. There is a difference between family history and genetics. We're going to talk about that in a minute, because we can have a family history of breast cancer. We can have multiple family members that have had breast cancer, and we do not have a genetic mutation. So there is a difference between family history and genetics. Genetics. So what are we talking about? We are talking about a deleterious mutation, a deleterious gene. So when we're talking about genetics, we are talking about women who have a gene, but we're not just talking about BRCA1 and 2. There's other deleterious genes that put someone at an increased risk for breast cancer. But compared to women in the general population who have a 10% risk of developing breast cancer by 80, women who have a BRCA1 or 2 variation are estimated to be about 70% by the same age. So there are some other deleterious genes, Paulby, Czech, Li-Fraumeni. There's several other deleterious genes, but definitely BRCA1 and 2 are so significant that you are definitely in a situation where you are being highly monitored, you are getting additional surveillance, and you are what we call a high-risk patient. And that patient is being monitored in a different way. We're going to talk about how we monitor high-risk patients in a minute. But what about those other genetics? So remember that the risk of developing breast cancer by 70 in the general population is about 10%. So if you've been in imaging or breast imaging or in the world of mammography for a little while, like me, I've been in it for about 25 years. Once upon a time, if you were a person that was high risk according to a risk assessment model, and you were recommended for genetic testing, they would just do BRCA1 and BRCA2 tests. There was not any such thing at the time as panel testing. Well, today we know a lot more about genetic testing, and we know a lot more about deleterious genes. And there are several, as I mentioned before. There is the Li-Fraumeni, ATM, CHEK2, CDH1, and several others, P10, Cowden syndrome, that put a person at a higher risk for developing breast cancer. So today, instead of just BRCA1 and BRCA2, a patient will get panel testing to see if there's any deleterious genes that may put them at an increased risk for breast cancer. So we're looking at over 300 and more genetic variants. Personal history, of course, about 5% of breast cancer survivors will develop a new breast cancer. It's also referred to as a subsequent primary breast cancer. We're not talking about a recurrence. We're talking about a new breast cancer. It could be in the same breast, or it could be in the opposite breast. So just having a personal history of breast cancer puts you at a higher risk for developing a brand new breast cancer. This is a big one. We're learning so much more about hormones in our bodies and menopause and menarche. A study in 2021 showed that the mean age of menarche in adolescent girls was 12 and a half, and that was in 2021. But the mean age for menarche for their mothers was 14. What has happened in these couple of decades that has changed the mean age for menarche, and what are the long-term impacts of this shift in hormones? Women are starting their periods at least a year and a half to 2 years earlier, and that is giving us a couple extra years of hormonal exposure. So let's just talk about that. Breast cancer increases, the risk increases with earlier breast development, earlier menstruation, and later menopause. Breast cancer risk is about 20% higher among those who begin menstruating before 11 compared to those who begin at age 14 or older. Likewise, women who experience menopause at age 55 or older have about a 12% higher risk compared to those who do so between the ages of 50 and 54. The increased risk is likely due to longer lifetime exposure to reproductive hormones. We're going to be talking about hormones today a lot because you're going to see a correlation: early menarche, late menopause. We're going to keep talking about this recurring theme of hormones and hormonal exposure. So what is causing this early menarche? What is making this happen? So several studies have reported that the mean age of menarche has decreased from 17 years of age in 1840, the year 1840, to approximately 12 years old in the year 2000 in the most developed countries, meaning us. According to the Korean National Health and Nutrition Survey, in Korea, the mean age of menarche decreased from 16.9 years of age for women born between 1920 and 1925 to 13.79 years for those born between 1980 and 1985. Women who experience menarche before 12 have a 23% higher risk of developing breast cancer than those who first menstruate at 15 years of age or later. So what is happening? Several studies have been performed to find out why young girls are starting their periods so much earlier. And it has been proven that early menarche can be caused for several factors, including subcutaneous fat, higher body mass index, sugar sweetened beverages, genetic factors, but it gets down to a lot of what are we eating, what are we putting in our bodies, our subcutaneous fat. Guess what our subcutaneous fat has in it? Estrogen. Okay, so let's talk about this. Postmenopausal hormones. We keep coming back to this. Hormones, hormones, hormones. The use of combined estrogen and progesterone hormones after menopause, also referred to as hormone therapy or hormone replacement therapy. It's proven that it increases breast cancer incidence and mortality. This is what's interesting. Discontinuation of menopausal hormones diminishes but does not eliminate the risk. Combined hormone therapy also increases mammographic breast density. Postmenopausal estrogen only therapy increases risk of endometrial cancer and is therefore only prescribed to women who have undergone a hysterectomy. I'll just be very transparent. I had a hysterectomy when I was very young. They took everything. And since then, because I was young, they gave me estrogen, but they did not give me progesterone. I asked why. And he said, because that put you at an increased risk for breast cancer. You don't need progesterone since you've had a complete hysterectomy. I thought it was interesting. I didn't know very much about that at the time. Did some research, and guess what? He was right. According to the research, that's what I've been told, and that's what I read, and it makes sense. But I also want to say that a lot of doctors, and this is just some food for thought. A lot of times doctors are treating menopause rather than the symptoms of menopause. If you're having menopausal symptoms and you're being treated for those menopausal symptoms, then that is a complete normal thing. If you're not having any symptoms and you're being given medication to treat something you don't have, it's just everything in life is benefits versus risks. Do the benefits outweigh the risks? And you have to understand what the risks are. And if you're not getting benefits, it's just something to think about. Hormonal birth control. Most studies have found that current or recent use of oral contraceptives combined estrogen and progesterone, there they go again, putting them two together, is associated with a small, about 20% relative increase in risk in breast cancer. So we're back to hormones and risk. It seems to be a repetitive thing. So there's definitely data about that, and we're back to benefits versus risks. Body weight. So the risk of postmenopausal hormone replacement therapy, hormone receptor positive, breast cancer is about 1.5 to 2 times higher in women who are overweight or obese. I'm going to back that up. The risk of postmenopausal hormone receptor positive breast cancer is about 1.5 to 2 times higher in women who are overweight or obese than those who are at a healthy weight. Why? Why is this happening? Well, higher estrogen levels are stored in our fat. It's not fair. Women, we get a bad rap. And trust me, I'm not hiding a slamming bod back here. I'm gonna keep my secrets behind the desk. It's tough being a woman. It's tough being a postmenopausal woman, whether it happened naturally or surgically. And there is no judgment from this lady right here, but we like to hide our estrogen storage right in our belly fat. And we're back to that. We're back to hormonal exposure. And where are we storing it? Type 2 diabetes. We just keep getting hit right in the face. A recent prospective study reported 26% increased risk of breast cancer among women with diabetes compared to those without the disease after controlling for demographic and lifestyle factors. We're back to that. So alcohol and tobacco, alcohol consumption increases risk of breast cancer. And you know, same thing with cigarettes. We can practice healthy lifestyles, and we also know that we can be the ideal weight. We can have never smoked a cigarette. We can have, you know, only drink red wine twice a week, and something can still happen. We can practice all the best things all the time. Something can still happen. What do we need to do? We're going to talk about that in a minute. But I think everyone knows that drinking excessively and smoking, these are not things that we should be doing. Chest radiation, obviously, if we've had chest radiation at some point, it's because we had cancer that we were treating. But in 2017, the American Cancer Society recommended that if you were a young female cancer survivor and you had chest radiation, you should be considered high risk and should begin screening at age 30. Breast density. Up until just a few years ago, we thought that breast density in and of itself was not a risk factor. It just made your mammogram harder to read. Now we know better. Now we know that breast density in and of itself is indeed a risk factor. The risk of breast cancer increases with mammographic density. Women with BI-RADS C or D have 1.5 to 2-fold higher risk of breast cancer compared to those with average breast density. This is very interesting, and I had never heard this till I started doing some research, but I found it very interesting. Bone density. Bone density is not thought to be an independent risk factor, but rather a marker for cumulative estrogen exposure. Now, we're not talking about low bone density, we're talking about high bone density. Women who have high bone density, it can be a predictor for cumulative estrogen exposure. So someone goes and they have a bone density and they don't have low bone density, they have really high bone density. What can it mean? It can mean that they have high estrogen exposure. Now, when you think about it, the ladies who have very low bone density, we often think of that as our tiny women, our frail women. We're not thinking of our women that, you know, are ladies that have our meat eating, milk drinking women. We're thinking of our tiny little ladies that could fall and break a hip. So they're actually associating high bone density with a cumulative estrogen exposure. This is some new information. I just thought it was pretty interesting. I also thought it was pretty interesting that there is an association with taller women and a higher incidence of breast cancer. It's just something I found in research, and I thought, wow, that's really interesting. Very interesting. 17% higher risk with every 10 centimeters. Very interesting. I didn't know that. So I hope I told you something today that you didn't know. I think most of us know that there's a few models out there. There's GEL, Klaus, BRCA Pro, and Tyrer-Cuzick model. There's advantages and disadvantages to all of them. The GEL only includes first-degree relatives, which can severely underestimate the risk in women who have breast cancer history in their paternal lineage. The Klaus model, it looks at your lifetime risk, but it doesn't look at your 5-year, and it doesn't look at some other personal habits and other things like that. BRCA Pro looks at some of those things like your age and your things like that, but it doesn't look at your non-hereditary factors. Tyrer-Cuzick looks at all the non-hereditary factors, first and second degree relatives, and it also looks for a 5-year and lifetime risk. So it can be pretty helpful, but there are some disadvantages with the Tyrer-Cuzick, such as it can take a little while to do that risk assessment. So I've been talking about high-risk patients and how you manage them. And if you work in an imaging center, in an imaging department, I am sure that you have seen this happen, where a patient has already been determined to be high risk. They come in for a mammogram, their mammogram is clean, and then maybe a week or two later, they come in for a breast MRI, and their diagnosis is they're high risk. Maybe they're high risk because they have a genetic mutation, they're BRCA1 or 2. And you're thinking, well, you just had a mammogram last week. Or maybe it's the flip. Maybe they have a breast MRI, and then a couple weeks later, they're coming in for a mammogram. And again, the diagnosis is they're high risk for, whatever, a genetic mutation or whatever else reason makes them high risk. And you're thinking, you were just here. So what is the appropriate way to manage a high-risk patient? High-risk patients should be managed with quarterly surveillance. And quarterly surveillance looks like a clinical breast exam twice a year, 6 months apart, and imaging twice a year, 6 months apart. That includes a mammogram, a screening mammogram, and a screening breast MRI, but 6 months apart. And so, for example, it can look like first quarter clinical breast exam, second quarter screening mammogram, third quarter clinical breast exam, fourth quarter screening breast MRI. Obviously, it doesn't have to be in that order, but the whole point is that you have a physician or a breast surgeon or whoever's managing their breast care doing a physical clinical breast exam on them twice a year, so they've got eyes on them, and then they're having imaging twice a year, but 6 months apart. So you've actually got imaging eyes on them twice a year. They're being seen 4 times a year, and they're being surveilled closely. If they come, what I've seen happen a lot of times is they'll come in, they'll see the breast surgeon who's managing them, they'll get their clinical breast exam, and then they'll go and get their MRI and then a mammogram, and they've had 3 of their 4 yearly surveillance things happen within 1 month. And then they'll wait 6 months and have the other thing. And they're not getting their quarterly surveillance. So there's a lot of misunderstanding about high-risk patients and the frequency in which they are supposed to be surveilled. Genetic counseling. A genetic counselor is a member of the healthcare team that's going to sit with the patient, help them understand what genetic testing will do for them, help them understand what the results would be and what the impact would be on them if they had the test, and would explain what all the testing results could do and just all the impact of that. And genetic testing is usually performed by a genetic counselor. It's collected with either blood or saliva, sent to a lab. Results come back as either positive, negative, or a variant of unknown significance, which can be a little difficult for people to understand. It means that there's a genetic change and there's just not enough data at this time to know whether that increases the cancer risk or not. When a patient has a variant of unknown significance, if at a later date it is determined that that variant does indeed result in an increased risk, then that patient is later notified that, yes, that does increase your risk. So it's good to have a relationship with a genetic counselor that's kind of ongoing if someone does indeed pursue genetic testing. I'm not going to spend a lot of time talking about screening mammography. We all know what screening mammography is, how important it is. The one thing I'll just say is that if you have a first-degree relative, for example, your mother or your sister had breast cancer at an early age, you're going to start your screening mammography 10 years before the onset, but not before 30. So if your mom had breast cancer at 39, then you would start your breast cancer screening at 30. You wouldn't start it at 29, you'd start it at 30. Contrast enhanced mammography has really taken off. We're doing that at my organization. It uses an iodinated contrast medium, the same like what we're using with CT. It's great for patients who cannot tolerate breast MRI. It's used to evaluate asymmetries, and the detection rate is very similar to MRI. It does require more contrast, or excuse me, more radiation, but it's really fantastic. You know, if a patient has an implant, so they're not a good candidate for MRI, it's great for architectural distortion. It's great for evaluation of, you know, potentially, you know, disease in the contralateral breast, if you're doing surgical planning. Has a lot of application, and we're really seeing it take off. Ultrasound, we know that ultrasound is a great tool for differentiating between solid and cystic areas. We can use it as whole breast for screening or targeted and specific. Elastography is a wonderful tool to help us give us additional information on the stiffness of a lesion. Breast MRI, we're using breast MRI all the time to not only do problem solving, evaluate for implants, but also to evaluate high-risk patients, anybody who has a lifetime risk of over 20%, who may have a genetic mutation like a BRCA1 or 2, POLB-check, ATM, and others. We know that the trouble with MRI is it has a very high sensitivity and a low specificity. Limitations include the cost, high false positives, and patient tolerance. So those are our challenging points. So just wanted to show you a couple of high-risk pathologies. These are real patients. We did a biopsy on this first one here. This patient had atypical ductal hyperplasia. That just means some unusual cells that are growing fast. And so for this patient, we had to monitor this patient and have her come back for short-term follow-up. This patient here, this one was, we had to recommend some surgical consultation and some additional things with this patient. She had lobular carcinoma in situ, which is used to be considered a cancer, but now it's actually considered a high-risk finding. This is basically a high-risk finding where you have some precancerous cells that are still inside the lobule. They haven't gone outside the lobule yet, and this is some unusual cells that are growing fast. Flat epithelial atypia is also a high-risk finding in combination with some atypical ductal hyperplasia. These are all high-risk findings. And this is nothing to worry about, usual ductal hyperplasia. So these are some high-risk pathologies that have to be managed either with high-risk screening, surgical consultation, chemo prevention, and sometimes managed with a combination of options depending on their personal risk factors or preferences. These are some patients that went to a multidisciplinary conference because pathologies came back and the radiologist wasn't sure how to, what they wanted their recommendation to be. So they recommended that their pathologies and histories go before the multidisciplinary conference for discussion. This patient had atypical ductal hyperplasia and flat epithelial atypia. The consensus from the multidisciplinary conference was surgical excision. This patient had atypical ductal hyperplasia and some lobular carcinoma in situ. This recommendation was for surgical consultation and discussion on risk reduction and possible endocrine therapy. And this last patient was the one I showed you on the previous page. And the recommendation, this was the lobular carcinoma in situ in 2 areas and the intraductal papilloma with atypical lobular hyperplasia. This recommendation was chemoprophylactics and an MRI and surgical excision of this intraductal papilloma with atypical lobular hyperplasia. So just a whole lot of things going on there. So I've just got a few more minutes before questions and answers. I want to just talk about increasing protective factors that may help prevent cancer. We've got our protective factors. There's, there's things we can do and there's things that we can't really change. We can't change when we start our period. We can't change when we go through menopause. And a lot of times there's things that we can't change. Sometimes we'd like to decide when we have kids and sometimes we don't get to decide that. But the following are protective factors: our reproductive history resulting in less exposure to estrogen. And sometimes if we know that we're high risk for whatever reason, if we have a genetic mutation or we've had a biopsy that shows something, sometimes taking selective estrogen receptor modulators or aromatase inhibitors or inactivators are appropriate. And that's something that a breast surgeon or medical oncologist might recommend. Risk reducing or prophylactic mastectomies for women with high penetrance gene mutations like the BRCA1 or 2. Ovarian ablation, getting enough exercise. These are protective factors. And just really quickly, we always have to overcome myths with facts. So, and we have to help people out in the community overcome myths with facts. We hear all the time people say, I don't have a family history, so I don't need to worry about cancer. There's no cancer in my family. But we know that only 5 to 10% of breast cancers are hereditary. The biggest risk factor for getting breast cancer is being a woman and growing older. So that's the truth. We know one of the biggest myths is I practice healthy living, so I won't get breast cancer. And even though I talked about all the things I talked about, we know that you can have never smoked a cigarette, you don't drink, you practice healthy living, you eat right, you exercise, and still you can get breast cancer. So although these behaviors might lower your risk, it can eliminate it. I've heard people say wearing a bra can cause cancer, but there's no evidence that can firmly say that happens. I've heard people say using underarm deodorant and antiperspirant causes breast cancer, but there's no evidence of that either. And unfortunately, I would love to tell everyone that if you have a mammogram and it shows that you do not have breast cancer, that is the God's truth, and that you don't have cancer if your mammogram says that you're negative. But although mammography is the best tool we have, it does not always find every breast cancer. It's estimated that we miss, and 20% is high. Actually, it's about 10%, but it depends on your breast density. If you have fatty breast tissue, that mammogram is going to be pretty darn accurate. But if you have dense breast tissue, it may not be as accurate. And the truth is, there's some cancers that they show themselves very clearly on mammography. Ductal cancers tend to show themselves very well. Lobular cancers are very sneaky, and they do not always show themselves. Lobular carcinomas tend to be not only mammographically occult, but also sonographically occult. And often we can only see lobular carcinomas on MRI. They're sneaky. So that is everything I have to share with you today. I do have a slide with all the references. You know, I didn't pull all this out of the air, but I want to give you guys an opportunity to ask me any questions that you have about the material I've shared with you today. I hope I told you something that you didn't know.
Great, thanks so much, Tricia. Yeah, we've got quite a few questions popped up. So the first one is, what is the financial impact for high-risk patients that follow the quarterly recommendation, and how should a facility manage the care?
Yeah, it's very stressful for a woman to have an MRI every year. Her screening mammogram is going to be covered by her insurance at 100%. Her MRI is going to be covered, but it's not going to be covered at 100%. It's going to apply towards her deductible. And that is a very tough situation. There's the insurance companies can't refuse her insurance based on her high risk status, but there is not a screening MRI. Even though it's actually coded as a screening MRI, it's still going to be breast MRI, and it's going to apply towards deductibles. It's a very tough situation. It's just like with a whole breast ultrasound. A whole breast ultrasound done for dense breast tissue is essentially a bilateral breast ultrasound, and it applies towards normal deductibles.
Yes, I think this probably leads on, and you may have covered it, but do insurance companies pay for MRI if mammogram shows dense breast tissue?
So you can use the CPT code R92.2, and they will pay for it, but what they're going to pay for is they're going to pay your normal co-insurance, and if you've met your deductible.
Okay, perfect. And going on to the subject of the height you mentioned, for any of these models, is height an input factor to determine risk?
Yes, the Tyrer-Cuzick model uses your BMI, your height, your weight. I'm very fond of the Tyrer-Cuzick model. It's my favorite out of all of them. It takes longer for the technologist or whoever's doing it to do it, but it takes into account first-degree relatives, second-degree relatives, your social history as far as your smoking and drinking. It also takes into account your BMI, your height, your weight. It's the most comprehensive of all the risk assessment models and gives you that 5-year and lifetime risk.
Perfect. So for the different risk models, is there a tool to synthesize data for a patient to incorporate a score based on data from all risk models?
I'm not sure if there is a way to incorporate all the risk models and get one sort of synthesized score. I'm not sure, but and I'm, you know, I get nothing for advocating for one over the other, but one of the models clearly is more accurate. One of the models takes into account more factors than any of the other models.
Perfect. We've got time for about one more question. Right, if there was one technology breast imagers could skip, what would it be?
So I wish that contrast enhanced mammography was a little more efficient. And if it was a little more efficient, then I would say let's just skip traditional mammography and go straight to contrast enhanced and do that on everybody. And that's in a world where nobody is allergic to contrast, you know, iodine-based contrast. Contrast enhanced mammography is, I really think that's like the technology of the future. Obviously, because I am you know, a technologist, I'm always going to say, please stay away from, you know, things like thermography and breast paps, from technologies that, you know, are not FDA approved. But contrast enhanced mammography is fantastic. And if a patient has dense breast tissue, definitely maybe if you have the ability to get a contrast enhanced mammogram, just skip a traditional screening mammogram and just get a contrast enhanced screening mammogram. Then you don't need the MRI and you don't need a whole breast ultrasound. You can just go straight to a contrast enhanced screening mammogram. Bam, you've got it all.
Perfect. Thank you so much, Tricia, for your time today. And it was a great and really informative presentation. Thanks so much. I'd also like to thank our sponsor, RSTI. Please visit their website, rsti-training.com, for more details of their training programs. Now, as promised, the answer to today's trivia question is purple. So congratulations to our winner, Stephanie Lale in Kentucky. Just a quick reminder, you can obtain your CE certificate by completing the post-webinar survey, which will be emailed 1 hour after the completion of today's webinar. You must complete the survey to receive your 1 art category A CE credit by the AHRA, and you'll be able to download the certificate directly from your computer once the survey is submitted. If you have any questions, you can reach us at webinar@mdpublishing.com. Please visit icewebinars.live for more details of all our upcoming ICE webinars and complimentary registration. If you've missed any of our past webinars, please visit icewebinars.live to view our whole webinar archive. Thank you all for your time today, and I hope you enjoy the rest of your day.